All right, so just a few words of introduction. As you know, at the University of Technology, we have 6 research areas, priority research areas, and these are listed over here. Computational oncology, sorry, and personalized medicine is the numbered one, but it doesn't mean that's the most important one. But in general, we focus on our long-term cooperation with the National Institute of Oncology here in Gliwice. So within that priority research area, we've decided to have 6 main sub-areas. So these are listed here. As you see, they cover a wide range of topics, and we have these coordinators of those sub-areas. They are listed here. So if somebody is interested in conducting the research or cooperation within that topics, please contact these people directly. Without them, we won't be successful in our, let's say, events, actions, and reaching the community. And together with these people who are the coordinators, we have a great support from the, let's say, advisory board. These are 12 wonderful researchers from all around the world, the different institutions. These institutions we have a long collaboration with, so they represent Europe, United States mainly, but also there are some from Australia. Here, I'm not good with this, okay. And then just to be close with the society, and we have extra 4 people who advise us how to reach the community. So we have people from those companies that also have been active at the university for quite a long time. And that's a very short info about that priority research area. If you would like to learn more, please go to the webpage, and there are more detailed descriptions over there. Just to mention, with our research area, there is the 2 centers, Biotechnology Center and the European Health Innovation Center. They are linked with us, and they are active members of all those activities we conduct here. So I am so fortunate and privileged to coordinate that research area. I'm very honored to be a part of that coordinators for the SUT. But today, let's focus on our session, which we decided to name Medicine of the 21st Century. It's already 25 years, so I think we can do that and try to compare that with what was previously done. And for this, for the discussion, I invited the wonderful people, great researchers. They kindly accept the invitation, and you have all of them here. So our keynote speaker for today is Professor Franks from Lund University. Then among us, there is Professor Małgorzata Oczko-Wojciechowska from National Institute of Oncology, Gliwice, Professor Oleksyk from the Oakland University. We have Dr. Jennifer Sargent from Babelfisk, Sweden, and Professor Sela Tupler from University of Modena. Just a short information about each of those panelists here. So our keynote speaker, Professor Franks, he's an expert in genetics and molecular epidemiology. He focuses on cardiometabolic diseases. His background is statistics also and biotechnology. He is right now with the Harvard School of Medicine together with the Lund University and Queen Mary University in London. He is focusing on using the machine learning tools for, let's say, developing models for improving the prediction, prevention of, and treatment of those cardiometabolic diseases. Professor Oczko-Wojciechowska, she is a geneticist by training and by practice, let's say, and he works with the, let's say, oncogenomics as a main topic of her research. She focuses on personalizing the cancer therapy, mainly by molecular classifiers, and she's the co-author of the already patented model that allows to distinguish between subtypes of thyroid nodules. Among us, we have also Professor Oleksyk. He's from Oakland University. Now he is a beneficiary of the Fulbright program, and thanks to that, he's staying with us and with the Polish Academy of Science in Krakow and the Jagiellonian University. And he's working mainly, and he's interested mainly in genomic diversity and the role of that in adaptation and disease development. We've been working together on the genome project about type 1 diabetes mellitus. We also have an option to listen and opportunity to listen and learn and about the experience from Dr. Jennifer Sargent. Yesterday we had a seminar, so some of you participated in that. Dr. Sargent, she is the expert in, let's say, promotion of diverse, equitable, and inclusive research. She also puts a lot of the effort into spanning the results and the understanding of precision medicine to public and global health. And she has a long-term experience serving as the editor to the top medical journals. Having background in biochemistry and immunology helps her a lot in let's say, achieving all the goals. And our, let's say, fifth participant panelist is Professor Rossella Tupler. She is now from the University of Modena in Italy, but she is an experienced and geneticist and clinicians working with the muscular dystrophies. We are so fortunate that we gained the European project within Horizon 2020 together, and she's the leader of that project. So a lot of her work is devoted to understanding let's say, the development of muscular diseases. Please remember, 60% of the patients are undiagnosed. There is no knowledge about what is the reason for the disease. So these are my wonderful guests for today. And before we start the discussion, I would like to ask Professor Franks to tell a little bit about the precision medicine in cardiometabolic diseases. So the floor and screen is yours.
Thank you so much for the opportunity to be here today, Johanna. I very much appreciate the invitation, and it's been wonderful to learn a bit about the Silesian University of Technology, which is clearly one of the rising stars in Europe, if not the world. And I find that fascinating because although I trained in Cambridge and I've had appointments at some of the world's top institutions, I come from a working class background, and I love to see the rising stars, both individually and of institutions. I think that's what makes the world great, and it's what makes humanity progress. So congratulations for everything you're doing here in Poland. I will talk to you a little bit about some of the work that I've been doing over the last few years in precision medicine. I have a focus on what we call cardiometabolic diseases, but as you'll see, I'll really sort of channel that towards diabetes, obesity, and cardiovascular disease. So type 2 diabetes in particular, but diabetes overall, is a global problem, and it will continue to increase in its impact globally. And as you can see, over the next 20 or so years, there's an anticipated increase in the proportion of the global population with diabetes in Europe and the US, and a fairly substantial increase. But frankly, that as much as we worry about that in Europe and in North America, it's not really where the major impact's going to be felt. It will be in other parts of the world, particularly Africa, where the prevalence is increasing dramatically and will continue to do so over the next decades. So it's a truly global problem, and it's one that has an enormous impact. Approximately 800 million men, women, and children today are estimated to have one form of diabetes or another, and by the middle of this century, that number will be roughly 1.5 billion people, so an enormous problem. When I left Cambridge in the early 2000s, I went to work in the US at the National Institutes of Health, and I had the enormous privilege to work with some American Indian tribes, Pima Indians, Tohono O'odham Indians, and Navajo Indians in particular, that have a very, very high burden of obesity, type 2 diabetes, cardiovascular disease, and other diabetes complications. The picture on the left here is of a Pima family at around 1900. And I think what you can see quite clearly, and this is typical of the tribe at the time, they're very lean people, very athletic build. And in fact, Pima and Tohono O'odham, which are two tribes that are closely related, were really known as warriors, a couple of hundred years ago, athletic warriors and then farmers. So they had this very physical stature to their culture. Unfortunately, as part of the US Land Reform Act, that destiny changed dramatically. The Hoover Dam was constructed. The Pimas, they live in southwest Arizona. They were irrigation farmers. When the dam was built, it obviously affected the flow of water into the farmlands, and it essentially, very, very rapidly, from 1910 to 1920, transformed the way in which these people lived. And with that came a tremendous great deal of suffering, and from that, eventually, a huge burden of cardiometabolic disease. And I'll go a little bit into the details of that. It's a fascinating story. I can't go too deep for lack of time. But today, Pima Indians have a prevalence of diabetes in adulthood, which is at 50 or 60% of that population. In Poland, that number will be something like 8%. So it's an enormous burden of diabetes. But from that, through research, a great deal has been learned about the etiology and pathogenesis of diabetes that the rest of the world's populations have benefited from. And in fact, a lot of the diabetes guidelines today are in one way or another influenced by the research conducted in Pima. So I don't know whether this is slow or... Oh, there we go. Okay. So I'm absolutely certain that there aren't too many epidemiologists in this audience, so I'll try to communicate clearly what these data slides show. On the y-axis, the vertical axis, you can see a percentage, and that's the incidence. That's the gradual increase in disease events over time. On the horizontal axis, that's the age of these individuals, these Pimas, from birth through to 25 years. And what this shows, first of all, is, and it's all about the development of either diabetes, type 2 diabetes, or milder forms of dysregulated blood sugar. But what it shows is if you were born to a woman who had diabetes before pregnancy, and you are Pima Indian, by the age of 25 years, about half of that population will have developed diabetes. 50% of that population get diabetes by the age of 25 years. In European ancestry individuals, it's almost unheard of that somebody would have type 2 diabetes at that age, and yet half of this population do. And as you can see, with the mothers, these are blood glucose levels measured in the woman at the third trimester of pregnancy. There's a reduced risk of developing diabetes. It's still very aggressive, though. So pregnancy diabetes or gestational diabetes really exacerbates the problem of diabetes in this population, and that's a concept called fetal programming. So it turns out the youngest individual in this population who has what looks like type 2 diabetes, in other words, it's not an autoimmune form of diabetes that we call type 1 diabetes, happens to harbor a mutation in a gene that controls the potassium and calcium channels in the beta cells, which are the cells that produce insulin. And as later research showed from the NIH, this mutation, if you carry that mutation, first of all, you're likely to be a bit leaner, but on the other hand, you will have less insulin response when you're giving a carbohydrate challenge. So what that means is, and when we consume sugar or carbohydrates, we normally pump out insulin in order to bring the blood sugar levels down again by shunting the sugar into other cells in our bodies. It means that in these individuals who have that mutation, they're just not able to produce enough insulin to get rid of the circulating sugar in the blood. And what that does, it increases dramatically it increases the risk of developing diabetes. So that's one of the genetic mechanisms that really drives diabetes in this population. And unfortunately, this group of, and this is now with Navajo Indians as well, if they have obesity, as many of them do in childhood, and they have dysregulated blood sugar levels in childhood, their risk of premature death increases substantially. And so it's not just about diabetes, it's also about longevity and all the suffering that goes on in between. So incredibly high burden of diabetes and obesity and cardiovascular disease in this population. And it was this work that I did back in the early 2000s that really set me on a path towards trying to understand diversity in populations, human populations and diabetes, and to try to find ways that we can attack these challenges carefully and intellectually in different parts of the population, and not just taking a one-size-fits-all approach that assumes everybody's the same. And that's what contemporary medicine does today. And so this new approach is termed precision medicine. So let me just quickly give you a run-through of how a diagnosis of diabetes works. So as I said, there's about 800 million men, women, and children today. When somebody goes to a doctor with a new presentation of elevated blood sugar levels, the doctor will then say, come back in 2 weeks and let's see if it's settled down. If it hasn't, the doctor will then seek an answer for why that chronic hyperglycemia is present. Now, it turns out that in some cases, and I gave you an example just then, there are monogenic forms of diabetes that can be diagnosed using genomic sequencing, and maturity onset diabetes of the young, or MODY, is the most common monogenic form of diabetes. It's still very rare, but it's the most common of the monogenic forms. So that can be very precisely, very accurately diagnosed using genetic sequencing. With type 1 diabetes, which usually occurs in children and adolescents, although can have an onset in adulthood, that's an autoimmune form of diabetes, and so measuring autoimmune markers can also, or is also used as a fairly definitive way of diagnosing type 1 diabetes, so a direct diagnosis with autoimmune antibodies. And then you have something called pancreatic type 3C diabetes, and this is when the pancreas has been injured, either by drug toxicity, blunt force trauma, surgery, these sorts of things, and the pancreas can no longer function properly, and this is termed type 3C. And that also has biochemical markers that clearly diagnose that condition, as well as other features. And then we have lots of other atypical forms of diabetes that are usually diagnosed with genetic sequencing. So all of these types of diabetes have a very specific diagnosis attached to them. But unfortunately, they represent between 5 or maybe even less than 5% of all the cases of diabetes globally. So the other 95% of cases, the 760 million people today, and that number's rising, they have what we call type 2 diabetes, which is this common form of diabetes, and you probably all know someone with that disease. And the really sad thing about it is it's just a diagnosis of excluding all of the precise diagnoses, the few that we can, and it's lumped into a bucket, and we call that type 2 diabetes. It is a terrible diagnosis. It's really inaccurate, imprecise, and of course, if it's an inaccurate and imprecise diagnosis, it's really hard to prevent and treat. On the other hand, it's the poster child for precision medicine, because of course we can do much better than we do today, and that's exactly what we're trying to do with precision medicine. Now, some of you will say, I think fairly, who understand lifestyle and diabetes and obesity, but shouldn't we just be exercising more and eating more healthily? And if we just followed those guidelines, everyone would be better off. Well, generally speaking, it's true that exercise is good for you and certain dietary features are good for you, and these are all wrapped up in our national guidelines. But it's not true that everybody responds equally to those standard one-size-fits-all recommendations. This slide shows the results of a clinical trial called Look Ahead that took people, adults, who had developed type 2 diabetes and then were enrolled into the trial, and it was testing whether an intensive lifestyle intervention of the nature I just suggested, compared with just a standard sort of standard of care, the basic recommendations. When those two were compared, the question was, would that reduce the progression to cardiovascular disease in these people with diabetes? Cardiovascular disease kills about 80% of the deaths from diabetes, people with diabetes, so it's a very, very big problem. So that was really the hypothesis that was tested. And for those who aren't used to looking at cumulative incidence plots, the fact that the cumulative incidence line for the control intervention and the active intensive lifestyle intervention are overlapping tells you that the trial essentially failed to prove or to demonstrate that the lifestyle intervention helped. There was no difference in cardiovascular event rates between the control and the lifestyle intervention, which was a big surprise. It was published in one of the very top journals, clinical journals, New England Journal of Medicine, but nevertheless, very disappointing result from the trial. Now, subsequent reanalysis of the data have shown some interesting things. This is now the same clinical trial, but reanalyzed, stratified by several baseline features. So at enrollment was an individual, somebody who developed diabetes earlier in adulthood or later in adulthood, so age of onset. Were they severely obese at enrollment or overweight but not severely obese? And did they have poor glycemic control? Was their blood glucose going up and down all the time? Or was it relatively well controlled with medication? These were the classifiers. And what it showed is that actually, if for individuals who developed diabetes earlier in adulthood, the intensive lifestyle intervention really did suppress cardiovascular event rates. So that would be a good recommendation for somebody who got type 2 diabetes, in their 30s or 40s or maybe even 50s. It seemed to work quite well there. But the group that did worst, surprisingly, also got this intensive lifestyle intervention, and they have really high cardiovascular event rates. So they're following all the guidelines that are intensified for this particular trial, but they have more cardiovascular disease. And the stratifier there, as you can see, is poor glycemic control. It means that their blood glucose levels were very difficult to control at the beginning of the trial. So that was really the defining factor. And when you compare that group to the group that didn't get the intensive lifestyle intervention, that group did much better. And so you might conclude from this that the standard lifestyle recommendations, when intensified, actually caused harm in this group of individuals. It appeared to lead to more cardiovascular disease. So very surprising, again, but demonstrative of the fact that standard one-size-all recommendations just don't work for everyone. Now, how many doctors do we have in the audience? Not many, okay. So, all right. Well, I hope you're probably aware that the way in which public health works and most medicine works is that we have a sort of one-size-fits-all approach. We say, okay, if we can change the population distribution by treating everyone, if we put fluoride in drinking water, we can reduce the number of cavities that people experience at a population level. If we reduce the salt in bread, we can reduce people's blood pressure at a population level, and so on and so forth. There are these population-wide recommendations. And that approach doesn't really care about the individual. It's not saying we want to treat each individual and see what we can do to help improve their health. It's saying, let's treat the population, and if we can get the population to be healthier, individuals will obviously have benefited. And that's true, providing everyone more or less benefits in the same way from these standard interventions. The point, the slides I just show hopefully conveyed the point that that's not true, and therefore the population strategy, the one-size-fits-all approach, is probably not fair to many people in populations. It will be fine for a chunk of the population, but it won't be fine for everybody. So that's where precision medicine comes in. So you have this population strategy, which we currently have, and that's been pursued for the last 30 or 40 years. Then you have this precision strategy, which is, from a research point of view, it's really about data processing approaches that help resolve heterogeneity in population characteristics, often using machine learning, artificial intelligence methods to cluster and identify homogeneous subgroups, and then maybe make recommendations around how you treat those subgroups differently from each other. Just to distinguish that from personalized medicine, which are often, those terms are often conflated. Personalized medicine is really about using data from that specific individual and then running what we would call an N of 1 trial, so testing whether they respond and then using monitoring in that individual to calibrate the recommendation. It's a bit different to the precision medicine approach, which is still at a population level. It's shrunk down to subgroups. And with many diseases, it's much more realistic to think of precision medicine than personalized medicine. Now, this is just a schematic to remind you of high school molecular biology, on steroids maybe, but also to make the point that today we understand quite a lot about how the human body works and how particularly cardiometabolic diseases play out. And it's also to make the point that we can measure things within this whole cycle, both from an environmental exposure point of view. We can measure nutrients and minerals and toxins, contaminants. We can measure these things directly, objectively, in urine and blood and saliva and fingernails and hair and so forth. We have assays for all of these things. And then, of course, we can measure biological features. We can measure the human genome using either genotyping or sequencing. We can measure the transcription of the genes. We can measure the proteins that are then produced. We can measure the downstream metabolites, and we can measure some of that over time repeatedly in individuals. And today we can do that in hundreds of thousands of people. And studies like the UK Biobank in the UK, 500,000 people have a lot of these measurements made. It's an astronomical boom in data over the last 20 years. And the job of people like me with this sort of statistical interest in precision medicine is to use that information to try to resolve two things from this very noisy data, this collection of information that we have at scale. We're trying to separate signal, in other words, the markers of causal processes that are relevant to disease, from the noise, all of the error and everything else that you encounter when you measure things in human beings, particularly in populations. And that's really what we're doing with the end game of identifying hidden structures. And hopefully, if you squint, you can see there's a lady's face there. This is actually done through a Gaussian suppression machine learning method to get back from a really noisy image to a slightly less noisy image. And to use that information to then help to predict disease and to predict treatment response. So that's really what we're doing with precision medicine for these types of diseases. So now I'm going to give you a couple of examples of work we've published over the last few years that I hope will explain a little bit more about the detail of how we do that. So this work was led by an MD, PhD, former PhD student of mine, Daniel Corral, who actually, tonight, the reason we have to rush off after this is because he won a big prize in Sweden for the work I'm going to show you now, and we have to go back for the prize ceremony and dinner tonight, so apologies that we'll have to leave. Anyway, so Daniel, very talented guy. So this is the first piece of work that I want to tell you about. And it's really predicated on this issue that not everybody fits the population expectations when it comes to exposures and disease. Now, this is not our work. This is work done by Juliana Chan from Hong Kong and others many, many years ago now that shows that body mass index, which is a very commonly used measure of overweight and obesity, is in a curvy linear fashion associated with the risk of developing diabetes. So the more overweight and obese people are at a population level, the more diabetes you'll find in the population. And generally speaking, when you intervene and you reduce people's body weight, you'll improve their blood glucose levels and you'll reduce the incidence of diabetes within the population. So that is true on average at a population level. But of course, there are some people who are lean, a BMI of 23. I have a BMI a bit above 23, just to give a reference. That some of those people go on and get diabetes, get type 2 diabetes. It's not that common, but it does happen. And there are other people who are very overweight and obese who never get diabetes. They stay free from diabetes their entire lives. And so although on average we see this trend in the population, it's not true for everyone. And in precision medicine, we're particularly interested in the outliers, the people who do not follow the population average expectations. So we came up with a method that uses genetics, and I'll try to make this interpretable to those for whom this is an entirely alien language. I get that this is probably not the right slide for this audience, but let me see if I can talk you through. So you have these two groups, if you can just visualize that to make it very simple within the population. People who are discordant for the common expectation. So in other words, they're at lower risk of diabetes, even if they're at higher risk of obesity. And you have other people who are concordant, and they're at higher risk of obesity and higher risk of type 2 diabetes. And we can predict risk of those things using human genetics data, which is what we did here. So we have a very robust panel of information that tells us about the genetic risks in individuals, and we can stratify people into these two groups of what we call discordant on the left and concordant on the right. So just try and keep those two terms in mind. Okay, so first of all, this is really just a sanity check. It's to show, and this is from UK Biobank, 500,000 people, that if you have a concordant genetic profile, you're at increased genetic risk. You may not be obese or have diabetes, but if you're at increased genetic risk of those two disorders, you are likely to die a little bit prematurely. And if you have a discordant profile, you're at increased risk of obesity, but a decreased risk of diabetes genetically, well then you're a bit lower risk. Okay, so that's just a sanity check. I mean, it's interesting, I think, but nevertheless, we would like to know why. We did a very convoluted analysis. This is called multimodal AI for an umbrella term, but essentially takes a lot of the information I showed you in that illustration of the cell and the central dogma of molecular biology. We took information for clinical phenotypes, things like blood pressure and lipids and inflammatory cytokines and so forth, and then combined that with information about people's metabolites and proteins and transcripts and genes. And you put all of that together using fancy machine learning methods. And from that, you can then start to look at the profiles of people who have a genetic discordancy or a genetic concordancy. You're not meant to be able to read this. This is done for lots and lots of clinical markers, about 5,000 clinical markers. It's then done separately in another study to ensure that we don't have false discovery, so it's a replication effort. And then from that, you can see on the left, these blue dots at the left of this line. That means that there's a decreased causal relationship between obesity and these features on the left, which are clinical features, that some of which you'll probably recognize: high blood pressure, dyslipidemia, cholesterol level, high cholesterol levels, these sorts of things. But if you have the concordant profile, you have an unfavorable clinical profile for the most part. So that's partly explaining why people will die a little bit earlier when they have that genetic profile. But interestingly, there are some clinical features where it goes the other way around. So from a large proportion of clinical measures, it's much better to have a discordant profile. But for these 5 features, it's actually worse to have a discordant profile. If I take osteoarthrosis as the example, so joint problems of no specific origin, and NOS is not of specific origin. This is obviously a bone disease that occurs, and there is an increased risk then of developing that type of disorder. So it turns out when you use the proteomic data in this analysis, you can actually pin that down to a single protein, which is called HS6ST. And that protein has, and this is work that was done by others, essentially a microRNA mechanism of action that drives osteoarthrosis. And so it's an interesting link there that takes it right down to the proteomic level to explain why that profile for that particular disease is increased in people with a discordant profile. So that's one very technical, using lots of complex omics data and genetics data to try to understand why people don't always fit the population expectations for exposures like obesity and many other diseases. This second paper that was published a couple of months ago is now looking at a much more sort of clinically pragmatic scenario. And what we did here is to take, so the ESC is the European Society of Cardiology. It's the main organization in Europe for cardiology. And it makes recommendations and guidelines for clinical practice. And in people with diabetes, the recommended prediction algorithm for cardiovascular disease is called SCORE2. Now, SCORE2 has 10 clinical features in it: blood pressure, lipids, and so on and so forth, glucose, weight. And these features are put together in an algorithm to predict cardiovascular disease in people with type 2 diabetes. So that's the recommended approach. So we used from a high level, a similar approach, this discordancy approach, to now take these 10 clinical features that are shown on the left and put them together into, it's a very complex machine learning method here, but essentially to do a conditional analysis where we ask how similar are each of these markers, conditional on how similar the other markers are to an individual's level of body mass index. All right? So do they fit the population average expectation across all of this information, or do they differ from the population average expectation? And when we do that, and then we array this using a technique called UMAP, don't worry about the details, it's just a cluster presentation method, what we can do is then start to stratify the population into these different clinical features. So 80% of the population do fit the population average expectation, so that they're the baseline concordant group, but 20% of the population don't. So some of these individuals have a discordant hypertensive profile, so they're particularly elevated in their blood pressure relative to all of the other clinical features. They really stand out in that way. Some of them have essentially a liver enzyme issue, so it's more about their liver, not so much their blood pressure or other features, but it's really about their liver, which is a major metabolic sink and hormonal regulator in the body. Some of them have a problem with their blood fat levels, and some of them have this hyperglycemic profile, and then some have a more inflammatory state profile. So this is just telling you that there are some people in this room, including me, who will not necessarily fit the average expectations. We may really stand out in how our blood pressure responds to our body weight and all these other clinical features, or it may be the liver, or it may be the blood glucose levels. So we're not all the same, and we can start to break that down using these methods. And that matters because you can then use that to help differentiate the risk of cardiovascular disease. MACE is essentially a composite variable of clinical cardiovascular events, and DM on the left is diabetes mellitus, or type 2 diabetes. And what this shows you in this is a plot of hazard ratios for those who are interested, that essentially these different profiles convey a different risk of either diabetes in the future or cardiovascular disease once you've run this additional algorithm over the top of the ESC's recommended algorithm. And in fact, what it adds, and keeping in mind it's the same variables, it's the same measurements, we're not adding any new information, we're just reconstituting the information. It adds a sizable proportion of additional predictive accuracy to the clinical model. So it's actually very useful from a clinical point of view. I know you're going to have to take my word for that because you're not clinicians, but take my word for it. Okay, so let's just wrap up now and think about how do we get all of this research into practice. Like, there's obviously a tremendous amount of research done in many, many fields, not least in precision medicine, but very little of that actually makes it into the clinic and changes the lives and well-being of patients and other people who are affected around them. So this is a model that we came up with through consensus a couple of years ago called the EPOS model. And it essentially starts by saying the current approach that we have to medicine is not wrong per se, it's just that it can be better. And so it's not about precision medicine throwing out the textbook on contemporary medicine. It's about building on top of it. It's not going to be a revolution. It's going to be part of the evolution of medicine. And so we should take what we can already learn from conventional clinical trials and epidemiological studies. No doubt about that. But let's build on top of that. And the way that we might build on top of it is to do this kind of stratification that I showed you of populations into these more homogeneous subgroups of people who are just more similar to each other than they are to other people in other subgroups, who might then get different interventions, different treatments, different recommendations. That's really what precision medicine is about. And then we have this personalized part that I talked about at the beginning, which is, you can take that from 2 points of view. One is an objective point of view. What are the things that we can measure objectively with high accuracy and precision in a given individual? And can we use that to help titrate, to help calibrate any recommendations that are coming from the precision medicine step 2 in this? So that's very important. So monitoring and devices, which I think might be particularly interesting to some of the people at this institution, is really booming as well, both in commerce but also in academia. There's a lot that can be done to measure features of how we respond to exposures, risk factors, and treatments, and of course that becomes very important in this era of precision medicine. But perhaps even more importantly are the subjective personalization features, and these are, at the end of the day, the rate-limiting factors that mean that even if you had the best algorithm in the world, the best medicine in the world, it will not work if that individual either doesn't have access to it or they're not prepared to use it. And so within all of this, even though it's step 4 in this approach, it has to be embedded into the whole process. We really have to keep the individual at the center of the whole thing and make sure that we learn at the beginning what's likely to work and what isn't likely to work from a subjective point of view, from the access standpoint to the preference, to the needs, to the literary capacity of an individual. Can you speak to them in a way they understand? Is it compatible with their beliefs, their religious beliefs, their cultural beliefs? All of these things are going to be very important. And if we can do all of that successfully, we'll move from currently what we have, which is a fairly high error and inaccurate scenario for contemporary medicine for complex diseases, down to one where we have much more accuracy and much less error. Thank you very much.
struggle with the microphones. Could you please check if they work? Because I think, look, you don't want, so I think I can take one. Would you be so kind and share with Professor Doppler? Oh, thank you, because I do not see next one. Thank you so very much. That was a wonderful talk. I think it explained a lot to the audience and what the precision medicine really means and what is also our role as the engineers in developing all this and gaining that knowledge from the data. I was just wondering and want to get back to that title of our session about the medicine of the 21st century. Do you really see the difference, or do you think there is a difference and that concept of the precision medicine is really getting, let's say, more popularity, if I may say, in the clinical practice? So I would like to learn your opinion about that. So we have the experts from different kind of fields of medicine. We have from the cancer research, we have the people from the neurodegenerative, let's say, diseases with type 1 diabetes. So let us learn how it looks like in your kind of field. So I don't know who would like to start. We've already had some opinion about the cardio, let's say, metabolic disease. So how about the cancer? So please.
Okay. Thank you very much that you can having me here. It's a big pleasure for me. I am a genetist and I work with oncology. My daily routine work is genetic diagnostic. And of course I can say yes, this is a huge difference. But the difference is related to the method we have now. We have next generation sequencing, and I think this is a game changer in genetics and also in oncology genetics. Because when we think about last century, 2 decades ago, we can analyze only one gene, 2 genes, short fragments of the genes, and we were thinking that we can find one gene, one marker, predictive marker, which can help us to decide about the treatment, and we can find a lot about response for the treatment. But now we know that this is not true. That we have to analyze a lot of genes, a lot of markers, classifiers, panels, sometimes the whole genome in the rare disease, and also this is in oncology. At this moment, we need to use next generation sequencing to analyze the 20, 30, 40 genes to tailor the precision drug. As it was mentioned at the introduction, this is really important to know what we find in the genetics, in cancer genetics, not only in the germline line, but also in the cancer cells. So now we, in our lab, analyze the cancer cells to tailor the best treatment for the patient. So this is for me the huge difference now and 2 decades ago.
Thank you very much. Yes, I think I am a geneticist and I am an old generation geneticist. So when I started, we had only chromosomes. And of course, I can feel, and I lived through changes, because I remember the frustration when I was in the medical office with a couple, with a child with a disability, and I knew that there was a genetic background, but I wasn't able to say anything else that, okay, this is something autosomal recessive, and that's it. And the only tool we had was to analyze chromosome. And now what I am telling to the people, the students and the people in the lab, we can really analyze at deep cells, tissues, the genome, trying to understand what is causing the disease. And now we can also imagine, and I'm thinking about physiopathology of the disease, to look at the system in a dynamic way. So starting, we have animal models, things that we didn't have at that time. And of course, This has changed my genetic counseling because I look at the family, I took the DNA, and now I know that I can do something better because, of course, what Professor Frank said can overlap to what we do in rare diseases, which is a completely different field. But, of course, I can tell there is a very vast world in front of us. And what I am telling to the students, the biotechnologists and the medical students, that medicine will be not the same, but they have to be prepared to this. Because the most important point at this time is to be prepared to the challenge and also to talk to people like engineers that are, in a sense, far away, because we feel the variety of biology, because as Professor Frank said, we have a cell, but the cell is in a tissue, and the tissue is in an organ, and an organ is in an individual, and the individual is in the world. So how many layers, how many components are driving the phenotype, so what we see? And I think this is a kind of very important moment in order to put all things together and work just to advance our knowledge and do what we dream to do.
So me?
If you
Thank you. First of all, I really liked your presentation, Paul. It was thought-provoking, and I kept agreeing with you the whole time. So, but one of the things that I was thinking about, and you and I went through a similar time in history of genetics. By the way, Joanna, you packed this with geneticists, so we are totally biased. And what strikes me now is that the genetic methods today produce a lot more data for a lot less price. So what we can afford now to do with sequencing was less than $100, was hardly achievable with $10 billion 30 years ago, right? So that is a huge thing. We're producing a lot more data, and now our bottleneck is not that. So now clinicians can afford genetic analysis on a scale that we could not imagine before. But now the bottleneck is that clinicians cannot understand that data. And engineers, especially bioinformaticians, are the ones that need to help them now to produce it and bring it on the plate in the form that they can just understand. And that is the biggest challenge now, and it's what probably the most relevant to this institution. And the second thing that I brought out of Paul's talk that was quite obvious, that different populations that we'll look at, different groups that we'll look at, are different genetically, and they have different predispositions to and risks and protective status for different conditions. And treating everyone the same way is, as you said, not fair to individuals. Understanding these differences in context is a very important thing. And now I have to reveal that I'm also an evolutionary biologist. And understanding that these differences don't just happen. They may be part of what your population is and was for thousands of years is very, very essential, very important question. And actually brings a lot of more understanding about who and what you are. A lot of these populations that have been studied before are in the west of Europe or United States. Now people are paying attention to Africa and Asia. And those places are very, very obvious to study because people think they are really different from Western Europe. There is part of the world that is coming under our radar and nobody really pays attention to yet. And guess what? That is where we are. Eastern Europe is one of the most understudied populations in the world. And paying attention to people with their particular differences, particular history of population, evolutionary history in this area is very important puzzle that can be put in the understanding of genetic diversity and genetic underpinning of disease in the world. So without seeing the whole picture, without seeing this puzzle, you might be missing the whole picture. And it's similar to that figure of the man you were showing. Let's see, you have that figure of a man, you have a general understanding of what it is, but the nose or an eye is missing. And that's how I see today a vision of genetic diversity of the world. So that's my 5 cents.
Thank you.
Maybe I can just sort of riff on that a little bit. I think there's really two reasons for pursuing, from a purely technical point of view, pursuing diversity in the human genome. The obvious one is that it's unfair not to, because if people with a specific genetic background respond differently to risk factors or medical treatments, and we haven't studied them, we won't know that, and so we'll be giving them wrong medicines or advice about risk factors, so that's really about health equity. But the other is, and you know very well about this, you know, the interesting thing is that the more diverse the genetic data is that's available on record, the better we can do with the genetic data from any single population. So it's actually advantageous to people of European ancestry for us to have genetic information about people of other ancestral backgrounds. We can put that together and we can start to make better predictions from that. And so that's sort of, you know, all boats are rising on the same tide if we can really gather as much information about the diversity of humanity as possible, not just from a genetics point of view, incidentally, also from a basic clinical understanding. So tremendously important, and I'd like to say to Taras, I'm a huge fan of the work that you're doing in Ukraine, and I think it's just so important to you know, to do that work and not to sit back as you know, frankly, many of us, I do, where we reuse and reuse existing databases that have been collected that represent, unfortunately, only a small fraction of global diversity, but because they're accessible, we use them, and what we really need are pioneers who go out and generate large new data sets and diverse populations, which is exactly what you're doing, so well done.
So we started to say, but I think the opinion about that, let's say, one of the weak points of the studies, and that accessibility and let's say, one aspect is that our data are not very representative if you think of the whole population, human population. That's a limitation. But that precision medicine tools you've mentioned, they are very attractive. But are they really accessible for all the patients all around, even the Europe, not mentioning Africa and Asia or the other countries? So I think that's the way we should also go and proceed for the future, not only focusing on identifying or let's say gaining knowledge about this, but also making that accessible. I think the opinion of Dr. Sargent will be here very valuable, and her experience in.
So I am also a geneticist by training, but that was many years ago, and so I want to come out a little bit here in defense of public health, and to think about scale. And I think that is really the true challenge. We have the technology, but even at $100 per person, that is infeasible for many countries to be able to implement genomic sequencing for their populations at scale. So I think some of the work that Paul has been showing, the sub-analysis from the Look Ahead trial, for example, which didn't use genetics to identify those subgroups. It used other BMI, age of onset, or age of diagnosis. So there are other factors, and I think that what we really need to do is almost come full circle and to say, yes, we've got all this brilliant, amazing genetic information, we have machine learning, we have so many high throughput technology tools at our disposal. When I say we, I mean us in Europe, in high income countries, even in Eastern Europe. But there's many places in the world and even places in Europe that don't have access to these technologies. So is it a matter of access to technology, or is it a question of how do we get around the technology to ensure that people are having the best healthcare available at a population level, but also at an individual level? And I think that is going to be the new challenge of personalized and precision medicine. How do you do this not without being informed by genomics, but on an individual level, how can you do it in a clinic without those genomic markers? So I think it's great as a research tool, great as a diagnostic tool in a larger setting, but when it actually comes down to sitting with an individual in the clinic, how do you manage to do precision medicine with very few tools available? I mean, there are some countries, there are many countries in this world where $100, I mean, that's a year's worth of healthcare across all disciplines, and so I think that's going to be our new challenge.
I think what Dr. Sanger brought up is very important, because we were thinking, we are developing this European project, and one thing that we want to develop is this atlas for neuromuscular diseases, exactly to make data available on a different scale, not only genomics, but also the MRI, the histology, and the clinical description, precise clinical description, in order to give tools for other less wealthy country to try to solve this problem. And when you were talking about this, I am thinking about a work that a person in my lab did, but not when she was in my lab, but when she was in Africa, because she was in Tanzania, and she wanted to set up a PCR method for leukemia, for characterizing leukemia. And we were discussing, looking, and trying to understand what we can do. But you know what? Children didn't have access to medicine, to the treatment. So you make the diagnosis, but then you don't have the treatment.
So that's very true. But let us think about, because we've mentioned about that, the access to the genomic data as the main achievement and supporting the precision medicine, also the need for the precise clinical data to perform the holistic analysis and the view of these things. But do you think there are other technologies that around us that may support us in that, let's say, more accurate, more even precise, let's say, more accessible tools for the diagnosis? Is the only, can we think about something that occurred lately and it's very kind of hot topics, and it was mentioned already?
I mean, I think Jennifer's point is incredibly important on a global scale. It's no good if we can't deliver the solution. I sort of try to make that point at the end. You can have the best precision medicine solution that you can develop, but if it's not accessible or affordable, then of course it's no use whatsoever. There's a beautiful example of a very pragmatic precision medicine solution in diabetes that I hope will address your question, Joanna, and I think you were the handling editor for this paper in Nature Medicine for TriMaster. Yes, okay, so there's a trial in the UK called TriMaster, and it's the only precision medicine trial in diabetes that's been published to date. And it's actually very straightforward. So the trial really sought to answer the question of whether 3 at the time common diabetes medications, something called a thiazolidinedione, something called an SGLT2 inhibitor, and something called a DPP4 inhibitor. Those 3 different drugs that were commonly prescribed when the trial was done. The question that the scientists sought to address was whether those drugs work differently depending on very simple stratifications. In other words, of somebody who was overweight or obese versus someone who was normal weight, and whether somebody had good kidney function or suboptimal kidney function. And so they were the 2 basic measurements that were made. You can measure kidney function with an assay called EGFR. That's easy and cheap to do. And body mass index is just a measure of height and weight in a simple formula. So with that, they demonstrated very, very nicely that actually you can make treatment choices for those 3 standard drugs based on these simple clinical markers. Very cheap, very easy form of precision medicine. Now, that's important all over the world. I don't think there's a healthcare system in the world that doesn't want to save money and resources. but particularly in low-income and middle-income countries. It turns out that DPP-4 inhibitors and SGLT2 inhibitors are both on the World Health Organization's list of essential diabetes medications, but they're not cost-effective, and so they're not accessible in many LMICs. And yet stratification in this way may mean that you can not reduce the cost of the drug, but because you're only treating a subgroup of the population where the drug will be more effective, cost effectiveness may improve. So that's a really pragmatic way of getting precision medicine out into low resource settings.
I can say that precision oncology is really genetic oncology. And I see two main challenges. The sensitivity, because usually, as I said before, we use a sample, tissue sample. And some really important druggable variants are less representative. And I have a privilege that in my lab works bioinformaticians, but this is not a routine. This is not usual in Polish laboratory, but this is very important because sometimes I did not see that this variant is in this sequence. So this is really important because a tumor is, this is very heterogeneous in a sample, in the cells. And the second challenge is genetic knowledge in clinicians. It was mentioned that this is really important because sometimes clinicians do not know that they can use some drugs and they can use some genetic tests, and there is some kind of reimbursement for these tests. So not every Polish patient, cancer patient, has even BRCA1, BRCA2 tests, but this must be really something, you know, fundamental. But this is not available for every patient. So sometimes the bases are more hard to provide than, I don't know, the genome sequence. So I think this is the most important challenges in precision oncology in Poland.
Can I add, and I wanted to combine the answer to both of you, was another challenge that I think a lot of us are working very hard in our directions, and we have seen cases, and you've seen cases in your practice, and I have seen things in my research. And one of the problems is that this knowledge is amplifying itself very quickly, and there are two things about it. Some of that, how this knowledge is shared, having the knowledge open and accessible to other researchers allows, as Paul said, you know, if you know something about Africans, then it's better for the Europeans as well. But if a lot of the research is done by institutions that keep proprietary data to themselves, that's not contributing to anyone. And so it may be that somebody's seen that mutation, but you just don't know about it. So from here, that comes another challenge, is to be able to create global resources through which we can access all that data and realize that things that we are doing and things that we're doing are not silos. They are not one thing that we only seen once, but being able to reach out to other researchers that are working on the similar things and join our forces in order to solve these problems. And in that sense, perhaps it's hard to help some of the countries where people can't afford either medicine or test, but reaching out in there, trying to create collaborative connections and incorporating knowledge is probably one of the bigger challenges now. That's how I feel it. In fact, we're trying to build resources now for classifying access to genomic data around the world, and just to realize that a lot of it is not accessible, and that's a big challenge.
I just would like to add that there are global bases. but not every lab is obligated to report their variance. So not everyone do this. This is the gap in the variance because not every lab reports this. So we should share the knowledge, but do we want to do this? Sometimes we do not.
Oh, yeah, absolutely. Do we want to do it? Does patient want to share the knowledge? In fact, that attitude varies from country to country. We have done that research, and you might be surprised to find out what people feel like in Poland is not what people feel like in Costa Rica at all. Europeans have some fears that have to do, for example, with individually sharing their data because they feel like somebody's going to take advantage of it. What we find out about other parts of the world, it may be quite the opposite. They want to share the data. I worked in Puerto Rico, for example, for 10 years. They want to share the data because they want to put their population in the what is that? In the view of the world. In fact, I think the research response in Puerto Rico is like 96% of people you ask to participate in research will, and in Poland, I don't believe it's that, right? So it's not the same everywhere. So you actually, that's another challenge, and we need to study and learn these challenges, but we can't assume that it is the same everywhere either.
And I think there's a huge difference as well between a research environment and a clinic environment. And so certainly in a clinical environment, particularly when people are under a lot of stress with a potential diagnosis, the willingness to share data would be much more limited. In the research environment, it's often mandated by organizations, particularly journals, that the data is shared. But then there are other barriers to that. Internationally, there are certain countries and parts of the world where those genomic data cannot be shared. And then there's also places where people do fear persecution on account of their ancestry, their religion, their community. And so there are a lot of social challenges associated with sharing the data. And I think that this is something that we all need to keep as an open discussion. Journals are certainly a great platform for that, but I think thinking about public health, thinking about the WHO, which is now developing guidance for use of genomic data within the public health context, and making sure that we're still engaging with those policymakers to think about the policies around research, open data, and sharing are going to be really important. But there are certainly, I wonder if we should also revisit, and sorry about this, Paul, I wonder if we should revisit what we actually mean by personalized or precision medicine here, and whether or not we do actually always mean on the individual context. And I'm just thinking back to a pharmacogenomics example that I provided in a talk that I gave for Joanna's students yesterday. And in that, there's a researcher in Africa who's been doing pharmacogenomics, and he's found a point mutation in an enzyme in the liver which processes tamoxifen, which is a very common breast cancer treatment. And it shows that in women of African descent, they often have maybe around 30 to 50% bioavailable tamoxifen. You'll forgive me, I don't remember the name of its final metabolite. And that suggests then that women of African descent need twice the dose in order to have an effective treatment. And so we don't necessarily need to think about people and their genetics on an individual scale in that context. We can say, well, you're an African woman, and therefore we should change the dose. And we obviously need to be doing clinical trials to make sure that that is safe. But when we think about precision medicine, I don't think we necessarily always need to think at the individual level, but we can be thinking about populations.
So it looks that we all agree, and that's not surprising, that the precision medicine is something that occurs more in research than in clinic, I'm afraid. There are some fields when that precision medicine is more frequently used. There are some other fields of medicine when it's not as popular, let's say that way, but in general, holistic view is something what we are looking for. There are some weak points, as we mentioned already, about accessibility, equality, and all those elements that are not covered by our research. But I was just, for the last round of our discussion, let's imagine that we are in ideal world, and then there are no limits for the funding, there are no limits for the patient's kind of awareness and support of the research. What do you think, what will be the next step for the medicine. Right now we have that precision level. We mention about the personalized level, but what could it be? Let's think, let's dream for a moment. Okay, so what would be the best from your point of view, from your patients, and what can go further, and how the AI, let's say, or maybe machine learning can support these dreams?
I can give my idea because, of course, we are dreaming of finding a new way to, in our case, as I said, we are studying neuromuscular disorder, which are disease of the muscle. People are weak because the muscle doesn't develop enough strength, and then there are a lot of consequences. And some of them can also die because the respiratory muscle or the heart are not working properly. So the idea is first to try to understand the evolution of disease in people with the same kind of genetic background, because we are reasoning in a different way. We are not looking at one variant and at one mutation, but we are looking at a system that is not working properly. And this, I think, it is something challenging, but also new. On the other hand, knowing, understanding the system, how it works, the hope is to find a part of the steps that we can work on in order to ameliorate the treatment, the cure, but also to learn how to prevent, because this is also at the other point. So my dream is, okay, let's say that I understand a lot of things, and then I say, no, don't do this, don't do that, do this, do that. And also, if I don't have a real pill, I can really slow down or prevent.
Well, I have rather pragmatic dream, and as we mentioned about resources, for me, resources and databases are very important because many times we find some variants we cannot assume whether this is pathogenic or not, and we looking for all the bases available, worldwide available, everything, also the publication, literature, everything, but sometimes we have no idea what it is. So the resources, but the resources not only about genetics, but the clinical issue also, the response, patient response for the drugs. And then I can ask AI, or we can call this, I don't know, Maggie, what do you think? I have a patient with this kind of variants, in this age, with this other clinical issues, and Maggie can told me, you can use this drug and you will have this response, and if it doesn't work, you can use another. So it will be, for me, fantastic.
I can't agree more with that, what you said. And what I just want to build on that, just to say that the answer to your question, Joanna, is as we accumulate a lot of data, and now we have a great tool that can analyze that data non-linearly, which meaning not in the way we used to do, because AI can make generalizations that are sometimes beyond human, paraphrasing Sudhir Kumar, who was here a couple of weeks ago, beyond human vision, because we tend to think linearly, and we might not be able to see these connections in these large amounts of data. So with this, we might be able to see connections that we would never seen before, thinking linearly like we do, and then move a lot further. And the outcome of this is what I think that every patient's dream is, or every treating doctor's dream is identifying every patient's problem so the appropriate solution can be found. And I think there was this great tool, there was this great data, and there's these great tools that we're having right now. We are on the brink of starting to take off really rapidly in approaching that. Well, we'll always be approaching that goal, we'll not reach it, but we're approaching that goal asymptotically to the point where we are going to be very close to be able to help people fairly, those patients, assigning them the treatments that they need. But that will take clinicians, biologists, engineers, computer scientists, etc. It will take all of us, because this is now a whole lot more complex problem that's ever been.
Thanks. So I'm agreeing with everyone here, but I'm particularly agreeing that prevention is the key. But I think there's also a role here for precision prevention. And so throwing out what I just said about public health. So let's pretend, as you said, we're in a health utopia. So my dream here is that we all have wearables, that we all have monitors, and that we all have high health literacy, and that our physicians are very open to precision medicine in their own context. And in this way, we all will generate vast amounts of personal data that could then potentially, I'm pretending there's no problems here with privacy, all of this, okay? We are in an extreme utopia. That those data are feeding into it, not necessarily a centralized place, but a place where they can be used, and then data can be fed back using these population averages or defining subpopulations, and then being able to either have very early detection or to have preventative, personalized prevention recommendations at the individual level or at the population level that can then be applied by local governments, by WHO, by national governments. And so there is a vast amount of data, and for that to be affordable, for that to be in a trustworthy place, and for us to be able to harness that, to be able to use the research tools that people like Paul are developing with the AI algorithms to be able to really figure out what's going to go wrong, either before it goes wrong or right at that moment or shortly thereafterwards, in a perfect, perfect world.
But does it mean that we don't need doctors anymore?
No, because we should be aware that AI sometimes lies, and we have to find the way to know where this is a lie or where this is a true. So this is not easy sometimes to get the right information, because we have a lot of information. We can ask AI, and we have really fantastic information, looks like really real data, real information, but sometimes this is really a deep, deep lie.
And the social and cultural context really feeds into that as well, and that is something that I personally don't think that AI is really going to get there.
Of course, just what you said is correct. On the other hand, yeah, in the ideal world, we should be able to have the opportunity to test what in a model what we found, because this is, for instance, yes, we have an idea, we did the analysis, but then we have to design an experiment or experiments to test, and this is, of course, the very important point, because in that way we can prove that the theory was correct.
Yeah, nobody has canceled scientific method so far, right? So AI is great to generate hypotheses, and that's it, only in that context I mentioned. And thank you very much for bringing that up.
I'm kind of looking at the audience, and I'm wondering what you all make of this, because generally speaking, you're not medical people, I think, but you're perhaps people who have something important to offer here. I know very little about engineering, so I apologize for my naivete when I say this, and you can snigger at me if it sounds stupid. But my understanding is that it's sometimes a lot easier to invent something than it is to manufacture it at scale. And I think the same is true with precision medicine, where we are at a point, and I will stress that there are fields in medicine where precision medicine is very much deployed in practice, and in oncology that's certainly true. Unfortunately, oncology or cancer is quite a different disease to many other diseases, and so some of the approaches really don't transfer very well, sadly. And then monogenic diseases, these rare diseases caused by single gene mutations, that's also a field that, where it really is genetics is really used in clinical practice. But in fields for many other diseases, these complex common diseases, some of which I talked about, we don't yet have, as I said, good precision medicine solutions in clinical practice. So as engineers, and I suspect there are some engineers in the room, I wonder whether you will be able to think about how do we get these, the generation of an idea, the research evidence to support that idea, but how do we then get it through the great filter of translation and scale it into practice and quality assure it and deliver it at scale? I think these are the real problems, and I think that's true in car manufacturing with EVs and so forth. You can have a wonderful vehicle, but will it ever make it to market, and will it actually be deployed at scale and ultimately be profitable? And the same will be true with this type of medicine. Will it be profitable, not to make money, but profitable, prosperous for human health and well-being? And I think there's a real engineering challenge there, and that might be where the cross-disciplinary process really comes into play.
Thank you so very much. I think that the final conclusion is that there is a lot of the involvement for the engineers which are here that may support development of those tools, those dream tools, or those daily routine things that will support doctors in the diagnosis and personalization of the medicine. We have not mentioned about that step. I thought that maybe somebody would say about that if you have particular understanding of what's happening in your genome, then you can think about particular drugs, new drugs that you can develop to treat the disease. So that was my thing for the next personalization level, that we'll be able, in that utopia world, be able to design a drug, very targeted drug for a particular patient, but probably not within the next 10 years, I guess, something like that. But everything is going so fast, so we don't know. So I think we are almost run out of time, because we should finish at past, and we have 5 minutes if there are any questions from the audience. So we'll take these. If there are not, I think we will go for, that's 5 minutes for the coffee break. So thank you so very much. Thank you to my guests for accepting the invitation and sharing your knowledge and expertise and opinion with us. Thank you, audience, for coming and for joining us here. And we believe for the future cooperation with the engineers all around the medicine, all fields of medicine. Thank you. Thank you so very much.